Good morning, everyone. Today we'll speak about the macroglia in macular edema surgical implication. We know that the functional impairment is not only a matter of physical traction, but also intraretinal reactive gliosis. And under traction, we know that the macroglia is activated, and the aim of this activation is to produce gliosis to protect the nervous tissue. GFAP is the retinal stress marker. And we know that the GFAP is produced by the Mueller cells and is expected to primarily increase under traction, under mechanical stress at the vitreoretinal interface. But also a different type of glial cells resembling astrocytes are responsible for the high GFAP expression in the inner fovea. So how the macroglia evaluation can act as in a therapeutic algorithm, because we can have information on the pathogenesis according to the traction, exudative and mixed form, and about the timing of the surgery, of course. So regarding the pathogenesis, how to differentiate between the tractional, exudative and mixed form according to the intraretinal changes related to. Recently, we published this paper that is a mechanical model of forces transmission through the Mueller cells. We know that the Mueller cells are straight in the fovea and they have a zeta-shaped morphology away from the fovea. And we also know that in relaxed configuration, the horizontal process that we call R2 are localized between the outer nuclear layer and outer plexiform layer, so inside the hyaline fiber layer. And they are also responsible for the damping effect. So in relaxed configuration, we have this kind of morphology with a theta angle that is 90 degrees. In case of traction, like in tractional lamellar macular hole, the theta angle is between 0 and 90. And so the R2 segment is beveled, but is not completely vertical, whereas in the myopic foveoschisis, the R2 segment is completely vertical and the theta angle is 0. So such changes in morphology of the Mueller cells under traction help us to differentiate the tractional forms according to the structural OCT cross-section and ANFAS. Let's have a look. So we published this paper recently, looking to the morphology of intraretinal fluid accumulation in exudative form and tractional form. And so it was a retrospective review of 72 eyes. We did a quantitative assessment according to the retinal thickness in inner nuclear layer and outer fiber layer, outer nuclear layer, and also a quantitative assessment according to the fluorescein angiography, blue fundus autofluorescence, and cross-sectional OCT. Inner nuclear layer increase only in exudative pattern, and the vessel density of superficial deep capillary plexus was lower in exudative pattern. And at ANFAS, OCT segmented level of outer nuclear layer, we can describe in exudative form, petaloid pattern, and in tractional form, we can describe the spoken wheel radial pattern. So, in case of exudative form, we have this petaloid pattern because of damage of inner outer retinal barrier. Whereas in tractional form, we have this spoken wheel pattern with the Mueller displacement, but with no damage of barrier, of a retinal barrier and inner nuclear layer. We have also mixed cases where we have traction, and at the same time, we have also exudative cystoid space. And as you can see here, after anti-VEGF injection, we have exudative cysts that resolved, but traction was still present. What about the timing of the surgery? Which information can we get from the macroglia? We know that the visual impairment is not only related to the traction, but also to the biological reaction. And this is the timeline of research findings. In 2017, we published this paper looking to the intraretinal changes in the first 90 micron from the ILM, so in the ganglion cell complex thickness. And then Andrea Govetto published the paper in the same year. He called this increasing thickness continuous ectopic inner foveal layer. And then we had an histological proof that this increase of thickness was related to the gliosis and to the activation of Muller cells increasing the GFP, that an intermediate filament. And then we published another paper later on looking at the difference in idiopathic and diabetic epiretinal membrane according to the reaction of Muller cells. So at the end, we can tell that at the beginning we have a wrinkling, then we have an enlargement of outer nuclear layer under traction, and then still under traction we have activation of Muller cells with formation of gliosis, this continuous ectopic inner foveal layer. So this is important because it can give us the right timing for the operation, for the peeling. So according to this paper published, we found that in diabetic one, the changes are different to the idiopathic one. In idiopathic one, as we said before, we have an increased discontinuous ectopic inner foveal layer, whereas in diabetic one, we have an increase of intraretinal cyst spaces and increase also of capillary free zone of deep vascular plexus. This is because the Muller cells are not healthy as in idiopathic form. So the GFP expression was higher after peeling in diabetic one because we can induce a damage during the peeling of ILM, damage of Muller, and so we can get more GFP on our ILM peel. So we have also proof with the ERM mineralometry that we published in 2018, where the sulfur increase in epiretinal membrane, and this one correlated with the increase of glial intraretinal proliferation. So if we see changes in traction, we'd like to do the surgery when still the retina can move back, therefore can recover visual acuity. We just published this paper looking at the postoperative 3D movements of the retina due to the release traction after the surgery. So we measure the shift of the retinal vascular crossing from RP after surgery. So we measure this, the length of the blue line is the relaxation index. So we measure the shift of the retinal vascular cross-linking. And we use this Pythagoras theorem. And according to the retest variability, the Bland-Altman in our paper said that the shaded area that you can see here represented 95% limits of the agreement between the two different examiners. And according to our result, a larger relaxation index was correlated with the better postoperative best corrected visual acuity when stratified, of course, by baseline best corrected visual acuity. And the improvement of visual acuity was correlated with the post-op relaxation index. So that means that post-op relaxation depends on the grade of intraretinal and epiretinal gliosis, which is the result of the bond between Muller cells and ILM sustained by GFP. So we need to do the surgery when the retina can still move back and when the gliosis is not so strong, because otherwise the relaxation index stays low and the retina does not go back, and the best corrected visual acuity cannot increase again. Regarding the last things, regarding the diabetic one, we don't have to think about the intraretinal gliosis, but intraretinal cyst formation and increase of capillary free zone deep vascular plexus. So we need to do the surgery before the cyst is too big and before the avascular zone, so the capillary free zone is not too big. Otherwise, we have the hypertrophy that we published a few years ago. So According to the macroglia activation and changes, we can have clinical findings on morphology of fluid accumulation and intraretinal gliosis. The etiology, according to the fluid accumulation in petaloid pattern, spocule pattern, will tell us if we have exudation, so we don't have to do the peeling, or we have traction, we need to do the peeling. Regarding the timing, in idiopathic form, we need to do the surgery before we have too much gliosis inside the retina and too much displacement. And in diabetic form, we need to do the surgery before the intraretinal cysts are too big or the capillary free zone deep vascular plexus are too big. Thank you very much.